Welcome to the Alex Salmond Show, where we look once again at the COVID crisis and examine why the virus is continuing to rage in so many countries and still at pandemic levels. In the USA, Russia, Germany, Ukraine and Turkey, infections are running at 30,000 a day or more. Hospital admission departments are buckling under the pressure and weekly death rates are into the thousands. Across the world, the death toll from COVID-19 is now beyond 5 million. And in the Northern Hemisphere, winter is coming. Today, we turn to the expertise of Professor Hugh Montgomery of University College London to tell us what is actually happening in the intensive care wards and whether new treatments are helping to bring the infection under control. Then Dr. Bharat Pankhania of Exeter University examines the policy mistakes which have led to the continuing high infection rates despite the high level of vaccination. But first, to tweets, emails and messages in response to our show last week featuring hit series Succession star Brian Cox, also known as Logan Roy. Some lovely personal stories here. First from Anne Todd, who said, "I've shared a lift with Brian Cox. I went to a uni event where Brian was interviewed for an audience in Edinburgh and he gave a really interesting account of his life in Scotland, his career and his experience of Hollywood. I got his autograph later as he stayed behind to share wine and nibbles with various people, including us students. Very down-to-earth, very intelligent guy who can see through all the Hollywood superficiality and is a genuinely caring person." Fiona Brown says, "Brilliance on another level. The decency of Brian Cox is a great mirror for the entire Alex Salmond Show, including every member of the team." Thanks, Fiona. "I need to get his book, and I'm reminded that there are others on my list too. Thanks to Brian Cox and all at the Alex Salmond Show. You keep me sane and hopeful for positive moves to Scottish independence." Marion Mason says, "This was so interesting. We went to Brian's talk this week in the town church in St Andrews. The church was packed full of locals and the talk was amazing. There was not a mention of independence or even Braveheart, but I can confirm there was an excellent turnout of indie supporters in the audience." And finally, Carol McLean-Smith with another lovely story. "My son was an extra in one of Brian Cox's films, and when it started to rain, Richard had to stand out in it too with no cover. Brian invited him into his trailer and made him a cup of tea. That's a real human." Indeed, and that is Brian Cox. Now, the vaccines are deployed, but the virus is still ripping through society. Professor Hugh Montgomery is both an outstanding academic and practising in intensive care wards of London. Here he is in discussion with Alex.
Professor Hugh Montgomery, welcome back to the Alex Salmond Show.
Lovely to see you again.
Now, we're in third wave of COVID across the countries of the United Kingdom. How much pressure are the intensive care wards under in this third wave as we approach the Christmas?
Well, it's interesting. It's geographically quite variable. So some of my colleagues are here in the north of England and the Midlands under a great deal more pressure than some of us are in London. We do have plenty of COVID patients in intensive care, but nothing like the level of the waves we had previously. But of course, what we've got to hope is that people continue to take the vaccine, get their boosters, keep their social distance, wear their masks, because this could still catch up. And indeed, there are always, as you know, huge winter pressures on the NHS, even if there were no COVID at all. We've also got to remember we're trying our very best in hospitals in the United Kingdom to catch up with the treatment of patients whose treatment's been delayed by COVID. So that might be hip replacements or it might be cancer care. And we do have to make sure that's prioritised. The other thing to remember, of course, is that if you are trying to run a health service for people without COVID, even a few COVID patients rather messes that up, because you can't put a COVID patient that might be infectious next to a person who might be vulnerable, such as an elderly person or someone coming in for cancer care. So you end up having to run sort of two parallel systems. So the numbers perhaps belie the stress that's put upon the system, and it's a good reason why we should still advocate very strongly for everyone to do their level best not to contract or spread this disease.
So, Hugh Montgomery, does that mean that although the vaccination programme clearly hasn't been as successful as yet in stopping the spread of the virus, it has interrupted and mitigated the effect of catching the virus and ending up in hospital and, worse still, in intensive care?
Very much so. So it greatly reduces your chance of contracting the virus. If you do contract the virus, whilst you produce the same number of viruses at peak when you're breathing out, that falls off much more quickly. So you're much less likely to transmit it to someone else. And furthermore, if you do get the disease, you're very much less likely, over 90% less likely, in fact, to end up on an intensive care unit or dying. So vaccines are highly effective and generally very safe indeed. So again, a very good reason for us all to get our vaccination and to get our boosters, as I have.
Now, the booster vaccination, we're both in the fortunate position of having had the booster vaccination. How confident can we be that having got the booster, then protection gets up to, well, nearly 100%?
Well, it is certainly highly protective. The issue, of course, we're not quite sure is how long after boosters the protection still lasts for. So whether we're going to be into a cycle of continuous recurrent vaccination or not is a little unclear. There does seem some evidence that for people who get vaccinated and then get mild COVID disease, that their immune response is very, very much better and perhaps even more prolonged. So oddly enough, as this virus circulates at low level, producing asymptomatic or mild disease, in vaccinated people, there may be even better protection to come, which would be good.
Why is it that it's better when you're getting vaccinated to, as it were, mix your drinks? In other words, if you start with AstraZeneca, you'll then get Pfizer for your booster. What is it about the vaccinations that make it better to have different ones as you go through the programme?
Well, I wish I knew the answer because I'd probably get some medical prize for it. It's not widely understood. This is a phenomenon known as immune augmentation. The vaccine, of course, pokes your body to recognize one specific viral protein. And you'd have thought that then if you got COVID or whatever, you would only respond to that particular protein. But in fact, getting the virus and the vaccine interact to augment a much broader range of immune responses. So that's a phenomenon, say, known as immune augmentation. And how it works isn't fully understood, I'm afraid to say, but it does work. So mixing and matching does seem to be valuable.
Now, let's turn to your work, Professor Montgomery, as an intensive care physician on the wards. Your armoury of treatments is now being greatly augmented. We first had the steroid treatments last year, then there's the antibody treatments towards the beginning of this year, and now we hear that there's going to be what looks like successful antiviral treatments. So there are kind of three ranges of treatments in your armoury if somebody's unfortunate enough to end up in intensive care.
Yeah, so we do have a raft of different ways of treating people. So perhaps you and I have discussed some of these things before. We learned very early on that patients were at much greater risk of clotting, and that was killing people. So we were able to deal with that. We were using this non-invasive ventilatory support, so these tight-fitting masks, to see if we could actually get away without putting some people on ventilators. We now know that that works. I guess it saves about 1 in 5 people that would otherwise need to go onto a breathing machine. So we know that works. We know that steroids, if you get acutely unwell and are admitted to hospital needing oxygen, also reduce your risk. They don't in the community. This isn't something for you and I if we're at home with this. It's for hospitals. That also works. There are some anti-inflammatory agents, such as one called remdesivir and others, that damp down this sort of rather exuberant inflammatory response that you can get. And we now know that those sorts of drugs, the anti-inflammatory types of drugs, can also help. Now, you also allude to 2 other very new sorts of treatment. One that was announced by Merck. It's still waiting full assessment by NICE, our national sort of organisation which evaluates medications for value. It's said to halve the risk of death for patients that come to hospital, or indeed risk of hospitalisation. And it does this rather cleverly by messing up the code that the virus uses to replicate itself. So it introduces lots of errors into the code, lots of mutations essentially into the code, which stops the virus replicating. But this is only one study, and the data are perhaps not representative of what we'd see now. Over 50% of the patients, I think, were from Guatemala. A lot of them, I think, had to have been in the very early stages of the pandemic. Hospitalization was defined as only 24 hours or more of admission, which isn't very much. And the hospitalization or mortality rate was over 17%. And we've never seen any such figures in this country. So whilst there's some optimism there, I think a lot of us are waiting for further data. And then you also mentioned antibodies. Now, this is quite interesting. So when you contract the virus, your immune system makes these proteins called antibodies, and they stick to proteins on the virus, and that marks those virus cells as ones to be killed off, for instance. So it helps you attack them. And it can also neutralize or block the spikes on the surface of the virus, and by attaching and blocking them, can stop those spikes being able to attach to cells to get into your cells. Now, of course, that's great if you get the vaccine. That's one of the things that does. It produces antibodies to the spike. It works if you've had COVID. You make antibodies of the same sort. But if you haven't had COVID or the vaccine and you get ill, then the question is, could you give someone the antibody? Now, you mentioned that Donald Trump had had this sort of treatment, and we now know that some of these treatments do seem to work. And these are cunningly engineered antibodies. They're man-made, based on human proteins, and some of them are modified to make them last a really long time. So the half-life, the time it takes for the quantity to drop by half of an antibody, is normally about 26 days. And some of these being pushed out for very, very much longer. So we have some evidence, for instance, from a trial called TACKLE done by AstraZeneca, that if you haven't had the infection before and you get these antibodies early, that your risk of death or hospitalization is greatly reduced. But actually also of value, these antibodies act like a vaccine. They give you the antibodies directly, and that protection might last for up to a year. Now, you might say, well, why do we need that? We've got vaccines, right? The problem is, if you've got cancer, if you're having chemotherapy, if you've got on other immunosuppressing drugs, if you've, say, had an organ transplant, you perhaps can't rely on being able to make those antibodies for yourself. And whilst vaccination's great in lifting lockdown for you and me, for some other people, that becomes a prison sentence because they can't get out and about anymore because there are lots of people and they haven't mounted a good enough immune response. So these new treatments are very, very good news, I think, for people such as that, because it releases them from their own sort of self-imposed lockdown and offers them yet another route for prevention. So I think putting it in the round, if we all behave sensibly, keep our distances, wear our masks, do the sensible things, wash our hands with the alcohol gel, etc., get our vaccines, get our boosters. If we can't have those, get the antibodies when they become available. Then with that and the armory of treatments, if you are unlucky enough still to get sick or make it to hospital, we're in a very, very much better place than when you and I first spoke over a year ago.
So does that mean, Professor Montgomery, that with that armory of treatments, with the vaccination programme, you're getting to work with, although we're still losing hundreds of people a week in the United Kingdom, yes. But for people in your position, treating in the intensive care wards, that you're going to work with a bit of spring in your step, knowing that you've got more ammunition in your locker?
It's certainly much better. If you're going to fight a war, you certainly want to be armed, and we're much, much happier with that. But I would reiterate that we aren't out of the woods yet. We've got to remember that perhaps 12% of adults in this country still haven't been vaccinated at all, and they're probably not going to. These are probably people who've decided not to get vaccinated. So we've still got quite a lot of people who could become ill, certainly lots of people that could spread it. And whilst the risks reduce greatly by vaccination, let's say by 90%, it still means that for every 10 cases you would have got, you're still going to get one that ends up on intensive care or dies. And as we've mentioned before, just at the moment, those small numbers can be grit in the machine. They could really mess up a healthcare system. And I'd like everyone just to remember how stressed the health service normally is in an average winter. If you go back a couple of years, we were hearing ambulance queues outside emergency departments and so forth. So let's all just try to be sensible and keep the heat off the health service so it's still there to provide the care, not just for COVID patients, but for the people whose treatment, for instance, has been so badly delayed in the last 20 months or so.
Professor Hugh Montgomery, thank you so much for joining me once again on the Alex Salmond Show.
It's my pleasure. Good to speak to you, Alex.
Coming up after the break, Alex turns to Dr. Bharat Pankhania of Exeter University for an explanation as to why the virus is not yet under control. We'll see you then. Welcome back. Dr. Pankhania, throughout the crisis, has provided an informed critique of the policy measures which have thus far failed to control the virus across the UK. He speaks now to Alex.
Dr. Pankhania, we're now 18 months or more into the coronavirus, the COVID infection, but still a huge number of cases in the United Kingdom every day. I mean, 30,000 new infections regularly. Are you surprised by the apparent inability of the vaccination programme to get to grips with these sort of numbers of infections?
I'm not surprised, I'm disappointed. And my disappointment is that we have mismanaged it in the United Kingdom, without a doubt. If we look at comparable countries in our neighboring Europe, Germany, France, Spain, Italy, their case numbers, their deaths, their management is better. And the reason we need to learn from them is simple precautions, simple, easy measures actually help, and they help suppress case numbers.
Can you put your finger on where these weaknesses stand? I mean, what it is about the management across the 4 countries of the United Kingdom, which has seen the infections still spreading at such a high rate? So
the premise that we have to always remember is this is a person-to-person spread of infection. We try to find all sorts of complicated ruses to keep the case numbers down. The key point is this is person-to-person spread. That means wearing masks in public places where there are other human beings in close proximity. Where would that be? Buses, trains, tubes, crowded shopping centers, etc. Second point is that whilst our immunization program has been good, unfortunately, some of that immunity is now starting to drop off. But that's not the bigger concern. The bigger concern is we have not fully immunized the younger age groups, and we have failed to grasp it and address it and accept that children do get infected, children do infect others, and children are sources of propagating infections into older age groups.
So when we last spoke in this show, Dr. Pankhania, you warned that the dangers of taking children back to school before a vaccination programme for teenagers. Have these warnings come to pass?
Unfortunately so, and it is extremely disappointing because at that point, I was saying the United States, Canada, Israel, European Union, all very good countries with very good scientists with whom we often work together. And for the United Kingdom to be a standalone from all the other scientists in all these countries where they have really good scientists made me wonder. Furthermore, it was even more disappointing, really hurtful, that we finally saw the Joint Committee for Vaccines and Immunization minutes 5 months later. 5 months later. It is extremely painful to see that. And the reasons given for making the decision not to immunize the teenagers in those minutes was extremely disappointing. It was based on very flimsy premises that it was marginally beneficial and therefore we're not going to go down this route. They got it wrong. Not only did they get it wrong, they published their minutes 5 months later.
Well, I can say as a decision taker in previous examples of threatening viruses, not as serious as COVID, but the swine flu, that what you wanted, what you needed as a decision taker was clear, but above all, timely advice from your experts, so that if you made a decision, that it would have an effect. Are you saying that both in terms of the SAGE committee, with its lack of expertise and people who'd be on the ground infectious disease control, and now in the vaccination committee with the endless delay before they make decisions, that these key institutions have proved not fit for purpose in this most severe of all pandemics?
Yes, and it is very disappointing because, Alex, infectious disease management is not super rocket science. It is pretty straightforward if only we would do the basics, the fundamentals. And the fundamentals are we need to suppress infections universally from all age groups. And if you suppress those infections, you create fewer cases. It's as straightforward as that. Furthermore, another example, finally, a year later, today, I hear the UK government is finally addressing the issues of ventilation. People like myself, and I am a lightweight, have been talking about ventilation for at least a year. And it's finally today being addressed that ventilation is a big issue and we've got to do something about it.
The case numbers in Scotland, not as serious as the case numbers in England in the last month, but nonetheless still the infection raging at a very high level. And we've had this enormous international vital conference, the COP26 in Glasgow. Does it make you a bit uneasy having 30,000 delegates and their entourages with maybe 100,000 demonstrators into a country of Scotland and a city where infections are running at a high level? How uneasy does that make you as a public health expert?
Yes, and whilst I'm 101%, if there is such a thing, subscribe to global warming and sustainability as an imminent danger, the idea in the middle of a pandemic into a small country of having, as you say, 100,000 plus delegates, of course there is an introduction of risk. Of course there is. And it will be interesting to watch the case numbers in Scotland further to COP26 taking place. Of course, it is a risk, and we know the science, and it's only a matter of time when we see case numbers rising. The good thing is, not to cast dark shadows on this event, which is very important, is at least most people are immunized with 2 vaccines, and therefore, even if they were to get infected, hopefully most of them will not be seriously ill, and very few will end up being admitted to hospital and being put on a ventilator, etc. So the pluses are that, of course, case numbers will go up, but I hope that there is a disconnect between case numbers and being admitted to hospital due to them being fully immunized.
Now, we're still in a situation where some hundreds of people are dying every week in the United Kingdom across the 4 administrations. But the amount of publicity about that seems very low. I mean, have we become not immune to the virus, but almost immune to the impact of hundreds of people dying every week? I mean, what is it that gets people inured to a dangerous virus circulating at such a level and killing so many people?
Yes, so there is that clear fatigue, and people just say, 40 people died today, and it's almost water over a duck's back. It is unacceptable. What we need is a comparison, because people have become fatigued, but we need a comparison, a clear indicator. In Germany, in France, in Spain, the daily death is X. In the United Kingdom, the daily death numbers are X++. And we need to constantly feed this back to the public that the UK is not doing as well as the European Union. Why? And what can we do about it to become as good as we can? Because we are not as good as we can be.
Now, Dr. Pankhania, if you had the ear of government, which many of us wish that you had, what would be the one measure you would say to the leaders across Scotland, Wales, Northern Ireland and England? What would be one measure you'd say, for goodness sake, do that now, at this stage in this pandemic?
You always have to act early. Early reactions, early control measures result in better control, more succinct control, more in charge of the outbreak. So early extensive actions is the best course of action. Delayed actions, delayed minimal interventions equals you never get into control with the outbreak. And in the UK, unfortunately, we have been delayed, limited actions, and as a result, we've never caught up. If we had early, extensive interventions, we would be in a better place today.
So, Dr. Pankhania, how confident can we be that if you're lucky enough to have had the booster vaccination, that you're not 100% protected, but you're not far off it? How confident can we be that once you get the booster, you're safe from this virus?
No, we cannot say that, and we mustn't say that. And for Secretary of State for Health and Social Care, Sajid Javid, to lay a lot of singular emphasis on boosters is a smokescreen. The important way of managing case numbers will be as follows. It is multi-layered. It has to be multi-layered. So you have to immunize people who have not yet been immunized. You have to give the boosters to the vulnerable people. And furthermore, you have to also address other issues. The other issues are equally important. The other issues being wear your mask, wear it properly, wear it in crowded places, wear it on buses, tubes, trains, and crowded supermarkets. Furthermore, the big elephant in the room that we're not addressing, and this is extremely serious, is the seasonal influenza vaccines, because it is already circulating in Europe, and we need the schools' seasonal influenza program to gather pace and momentum, because they will infect other age groups. And we know that the strain that is in circulation makes poor immunity amongst elder people. So we need to suppress influenza very much so this year. So it's a multi-pronged approach, multiple layers, as well as please attend to seasonal influenza immunization urgently.
Sound advice, Dr. Pankhania. Let's hope it's implemented. And thank you so much for joining me once again on the Alex Salmond Show.
Thank you.
In recent weeks, many Northern Hemisphere countries have been registering epidemic levels of coronavirus infection. Even in New Zealand, the exemplar of liberal democracies in virus control, cases are on the rise in the summer, albeit still at tiny levels compared to other countries. The vaccines have weakened the link between infection and hospitalisations and deaths. But worldwide, 50,000 deaths are being recorded each and every week. And even high vaccinated countries have failed to crack the epidemic. Meanwhile, the logistics of the rollout of the vaccine to the developing world looks painfully and irresponsibly slow. In the 4 administrations of the UK, it is clear that the decision to resume the school timetable before the start of the teenage vaccination programme has been a key driver in the continuing high levels of infections. Better news comes in the success of new therapies, which add to the armoury of hard-pressed intensive care medical staff. But the combination of intense pressure from COVID and normal winter illness make hospitals a difficult and a dangerous place to be. This all points to a health crisis at Christmas. No doubt it will still be merry, but will it be safe? But for now, from Alex and myself and all at the show, it's goodbye, stay safe, and we hope to see you all again next week.